Mr. Luis Gospinheiro to make the official opening for this workshop. Thank you so much for the participation of all.
Hi, thank you, Diogo. Hello, everyone. Thanks for being here. This is the first event that the shared services of the Ministry of Health organizes during the Portuguese presidency of the European Union. I'm really sorry that the pandemic crisis prevents us to meet face to face, to meet of meeting in person. And also I feel really sorry that it deprives you of the great weather that we have here in Lisbon right now, but we will try to benefit from it for all of us. The Portuguese presidency of the European Union aims to promote greater cooperation between member states in the field of e-health in order to enhance the capacity of health services to respond to citizens' needs. In this regard, or having this in mind, we have made it a priority to promote digital health and have developed a 6-month program focused, among other initiatives, of course, on moving towards a data sharing ecosystem. For this reason, we consider e-health to the main axis for increasing the quality of health care and for reducing inequalities in access by the European Union citizens. To give just a brief introduction to the main digital events initiatives that we are going to perform during our presidency. In early June, we will host our main event, our main digital event. It will be the eHealth Summit.pt with a focus on telehealth, innovation, and digital transformation in health. This event will be followed by the 19th eHealth Network meeting. I'm sure some of you already know that. Also in June, we would like to subject to ESPCO Health a policy statement to promote a political debate on the state of digital transformation healthcare, but specifically addressing the removal of existing barriers to cross-border telehealth services. To support that, we are conducting already a proof of concept on cross-border telehealth services without barriers, and we are doing this to prove the technical feasibility and usefulness of this type of cross-border services. We are thinking about, for instance, a teleconsultation. And these two main initiatives, the proof of concept and the political statement, will be supported by two workshops, this one that we're having here today, and another one in May, to promote a discussion about the removal of barriers to cross-border telehealth. As you are going to see, in order to organize the discussion, we divided both the barriers and the enablers of cross-border telehealth into 6 different categories: legal and regulatory. Of course, we are talking about legislation and regulation barriers to not only within the country, but also related to European Union regulation that are affecting cross-border telehealth. Organizational or public administration barriers or enablers. For instance, administrative processes that, such as scheduling, planning, existing agreements for healthcare at a cross-border level. Technical, we are talking about interoperability, standards, available technology, security, etc. Financial, like reimbursement, financial support, and others. Clinical, the clinical protocol, referral process, responsibility, good practices, and cultural, of course, like language, trust, knowledge of existing services, and so on. So I hope this discussion will be fruitful in order to identify a significant group of barriers and enablers that we can focus on in order to try to remove the first ones and to push the to support the other ones. And thank you all for coming, helping us on this. Thank you.
Thank you so much, Luis, for the debriefing, and of course for the excellent remarks, and welcome to the session. So right away, I'm going, let's say, to present the overall agenda for the day, and to speed up a little bit. So the two main blocks that we do have here, it is about a presentation about, let's say, the cross-border telehealth, a kind of a global overview. Then we are going to have, let's say, two countries, and one country and one region that will present, let's say, the EU perspective about telehealth services. And then behind the EU, we are going, let's say, to have two presentations from Scotland and India. This is going to be one part where we are going, let's say, to see excellent presenters to give their overview about this dimension. And after the coffee break, our main objective is really to be a workshop, a brainstorming session between all the participants in this session about the challenges to cross-border telehealth services in the identified clusters or initiatives that Luis have presented to you before. So I'm just making use of 2 minutes just to present to you the context and what it is the problem here. So in terms of the what we are conducting and why are we addressing cross-border telehealth services, the main problematic is the following. If someone it is still with the mic, if you can mute yourself, it will be please. Okay. So in terms of why are you addressing the cross-border? Next slide. It is really about how can we provide the best healthcare treatment across border, and how can telehealth services would be a functionality. So the concrete problem it is how can a Portuguese citizen or an European citizen, when traveling to the country inside of the European Union, and after a willingness or after a specific emergency treatment, how can I have a proper follow-up in the country that I'm visiting? So this is one dimension that we believe a proper follow-up from the country of origin and the country that I am visiting could be very much needed in terms of the telehealth services, and how can we ensure quality in the healthcare delivery by the two different systems, by two different healthcare providers in two different countries. So this is what is the issue of this 6 months program of the Portuguese presidency under the digital health. Next slide. So as Luis have said, this is going to be a kind of a stepwise approach. The first workshop that we are conducting here today on the addressing existing barriers and enablers of the cross-border telehealth services. The second workshop, it will be more focused on addressing and how to remove barriers to the type of services that we specify. And of course, in the eHealth Summit.pt on the 1st and 2nd of June, to have a discussion and a broader discussion with stakeholders and of course with public entities and providers about this specific dimension. So this is, in a way, it is our calendar. So some practicalities for the day. So in terms of the question, next slide. So the question that you would like that you will put to the speakers, you can use the menti.com. So after all the presentations by the speakers, we are going, let's say, to pop up all the questions that we do have to the speakers in the screen. So you just need, let's say, to use your browser and to go to menti.com and to use this code. And we're going to open for a 5-minute question after the end of each presentation. All this data will be available in the chat. And if there is any need or a specific question that we would like to address, you can use the chat as well. So to don't waste any time, I think we're going, let's say, to move for the more practical. So the first speaker will be the Vice Executive Director, Mr. Frederick Levens from the International Society for the Telemedicine and eHealth. So Frederick, I will now give you to the floor and wish you a very good presentation on your side.
Thank you very much, Diogo. Hello, everyone. Thank you also to our hosts, the Portuguese EU presidency and the shared services of the Ministry of Health. It's a pleasure to be with you here today, and I'll give you a brief view on some global perspectives when it comes to telehealth and cross-border telehealth. This will in no way be comprehensive, but it just gives you a few pointers, a few ideas, a few practical examples also from our network. Now, before doing that, I would just like, for those of you who are not familiar yet with the International Society for Telemedicine and eHealth, tell you a few things about our global network. It was actually started up in the 1990s, mainly by physicians and other healthcare professionals, nurses, etc., who in those days were already active and interested in telehealth, telemedicine. And then since then, it has really grown out to become a network not only of healthcare professionals, but of all other types of stakeholders, organizations, policy makers who are involved in and active in the field of telemedicine and e-health. You can actually move on, one slide. This just gives some reference, some names of some of the organizations, companies, associations that are a part of our network. And as I mentioned, it includes healthcare providers and professionals, but also industry representatives, the companies and the organizations making the technologies, making the products. It's also a network of researchers and educators. And on the next slide, you will see that what we do is it turns very much around networking and sharing knowledge and experiences across geographical borders, across countries, across continents, but also across professional borders between those different stakeholder categories. One additional point I want to mention is that our network, our association, is recognized as an NGO in official relations with the World Health Organization. And this is of interest and of use to us as a global society, but also to our member organizations, because this provides opportunities, let's say at a policy level, global policy, but also national, regional policy level, to be actively involved or to actively take part in a number of meetings and events that are organized at WHO level or by the regional WHO offices, and to also in the end make your own voice and your own experience heard at those levels, and be able to make a difference in the end, and also push some of the policies, national and international policies. Next slide. This is just a very opportunistic call to all of those here present who are not yet part of this network to join us. We would be very pleased to engage with you on these topics. Yeah, you can move on to the next one. This is really where we get to the topic of today's workshop. And as I said, I can't, the global perspective will take us days or weeks to present and to discuss, but I just wanted to highlight, for instance, this document that was actually set up. It's a white paper, is now about 2 years old, but it was produced by the International SOS Foundation. That's actually the foundation arm of International SOS, which is an international health assistance company with also telehealth services. And they obviously in the field, on the ground, daily are faced with cross-border situations where they also provide telehealth, teleconsultation services to global travelers, to expatriates living and working in other countries. And so in this white paper, and you can see the references there at the bottom where you can find the full document, they have provided just a few examples, also looking at national and national legal and regulatory requirements and situations, providing a few case studies. And they mention and talk about some of the things that have to be taken into account when doing cross-border telehealth, which comes down to making sure that you also work with licensed or locally licensed physicians or health professionals, taking into account the local situation, being aware, for instance, of any potentially local diseases or health threats that may be occurring in certain countries, in certain parts of the world, making sure that prescriptions can also be filled, that medications are available in those places, etc. So you do need to have that sort of local assistance or work together with locally licensed and experienced physicians and other healthcare professionals. So from our network, this certainly was a very and is a very useful and interesting white paper with all the knowledge and experience, of course, that is behind that from the International SOS organization and foundation. The next slide just shows you something which I picked up very recently from the TBHI Institute in the US, where actually, similarly like in other places, other continents, you do indeed have those sort of restrictions across states within the US, where physicians have to be licensed by a specific state to be able to conduct consultations, etc., with a citizen, with a patient in a different state. One of the things that we've seen in the past year all around the world, of course, is that a lot of the let's say, the regulations or the restrictions have been relaxed. A lot of things all of a sudden were possible because of the sheer need and urgency of the situation. But at the same time, as and if let's say the health threats and the pandemic goes down, some of these restrictions will be coming up again, and what was sort of allowed will not be allowed anymore. And so there is a need for more structural inclusion of some of these topics in the regulations, in national health systems and so on. But the good thing is that we saw over the last year that it was possible. So we have to learn from those experiences, see what worked, what did not work, what has to be improved, and how this can be embedded sustainably and structurally in healthcare systems. So next slide. Yeah, that was just a highlight of those requirements. What I'm showing here is actually a couple of things that are in process, that are in the works within our International Society for Telemedicine and eHealth. And although they are not only or not strictly really related, or they were not started up with the, let's say, cross-border issues in mind, they actually may have some effects or some importance for good cross-border telehealth services and policies in the future. And so that's why I wanted to mention them and refer to them. In the first place, we are working with an organization called Emergo, who is working around compliance and regulatory support, mainly for manufacturers, for technology providers, etc., to make sure that if and when they move into new countries, into other countries, that they abide by the let's say the local regulations, the registration requirements for their technologies, and so on. And so this could certainly be something in terms of technologies, in terms of certain products and devices that are being used, could be a step towards more harmonizations and making sure that a product that is produced in or a service or a platform or any software and app that is produced in one country can safely be used in another one as well. So I look at that as a cross-border issue. The second topic is around accreditation and certification of telehealth services, of the service provider organizations, which in accreditate, this is about quality assessment of those services. And so there also, this could be something, and this is something where we want to work together with national legislators to look at potentially embedding some at least references and maybe ultimately some requirements for accreditation programs to be taken up and for service providers to be accredited against programs. We do have yes, we do have a number of accreditation organizations whom we are working on with that. And then there is the topic of workforce training, but also education for new students to make sure that they are well acquainted with the new technologies, with the new ways of delivering healthcare services. And so this is also something that could prove very beneficial in the end for cross-border activities. And the last one, legal insights assistance, is just beginning, but that's again something we get many requests for. And yeah, with that, one slide. Yeah, I just put this in because this is from your Portuguese and national telehealth plan, and actually there are quite a few things in there. It's a very, for those who haven't seen it yet, I strongly recommend you have a look at this. This was set up also a year and a half ago, I think. A very extensive, comprehensive strategy, and some of the things mentioned in there also are linked to with some of the items I just mentioned. So with that, I think I am at the end of my presentation. I welcome you to, as I mentioned before, to get in touch with us, to engage with us. We would love to hear what you are doing and what is happening in your regions, in your countries. So thank you very much.
Thank you so much, Frederick, for your presentation, of course, for an accurate overview about the current landscape. So just two questions. You do have, let's say, more or less, let's say, 5 minutes for you to answer to some of them. If you want, let's say, to take the floor, you can decide which one you would like, let's say, to take first.
Yeah, okay. I see already the first two ones related to patients. Is training for patients. Well, I refer to training for professionals, training for people in the workforce. At some point, yes, patients also and health literacy, digital health literacy is an important topic. So there are members and organizations in our network who are more closely linked to patient, or who in the background are linked with patient organizations and so on. So this is definitely something to be taken up in some of those structures. Are patients connected to the program? Well, I'll take that as are they connected to our organization? As I just mentioned, we do have some links, and we have been working with some international patients organization, with the European Patients Forum at some of our past events, etc. So there are some links, there is some collaboration. And on national levels, on local levels, again, we do have a number of institutes, a number of organizations who are definitely also working with and involving patients and patients' organizations in their work. A question from Estonia around accreditation. Well, yes, you may have seen that on the slide and the topic of accreditation, there were a few organizations mentioned. Two of them are out of the United States, but they are active internationally. Another one is out of India, QAI, the Quality and Accreditation Institute. And so they actually do, some of them even for 20 or 30 years already, do accredit healthcare organizations. They also have specific programs around telehealth. So this is happening, but we want this to become, for the, let's say, the telehealth service providers and organizations to become more aware of this and to see if this can be more structurally embedded, as I said, in some strategies, national requirements, or at least references and so much. Who is financing our network? Our association is a non-profit association. It's actually registered in Switzerland, and we we have it's a membership organization with membership fees. So that's how it's financed. But on behalf of the members, there is a lot of voluntary input as well as into all the activities that we do. What else do I see? Where will patient data be stored? Well, one thing I didn't touch upon was indeed data infrastructure. I consider that as something, that indeed has to be in place. And I know that certainly also Portugal has been very active in some of the European programs around data exchange, data storage, and all that. This is certainly a prerequisite. You need to have that basic data infrastructure, that health information exchange infrastructure, a sort of e-health highway needs to be in place, needs to correspond to and with GDPR regulations and all that. So this is clear. Our focus is of course more than on the, let's say, the practical applications in terms of telehealth services and so on that you can build on that data infrastructure and highway. And I think with that, yeah, we have already filled up the 5 minutes of Q&A. So thank you very much for all the questions. I'll be happy to continue with you the discussions offline, per email, or at future events.
Thank you so much, Frederick. Sorry for this kind of only 5 minutes for Q&A, but I think we do have a lot of things to discuss later on. Right now, we are going to have, let's say, the second presenter from the Portuguese National Telehealth Center of the Shared Services of Ministry of Health, Duarte Sequeira. I will now move to you the floor.
Thank you, Diogo, and also thank you, Frederick, for sharing us this initial thought. Hello, everyone, and thanks for joining us today. So I will present our perspective here in Portugal. As Diogo said, we have a National Center for Telehealth that conducts several initiatives in terms of promotion and development of telehealth initiatives. So let me just the screen, okay. So as you all know, patients and healthcare professionals have been working together for several years. In general, we have this traditional face-to-face relationship, but we are now facing really a great shift for a new paradigm when patients can meet doctors whenever they need and wherever they are. Of course, COVID-19 was a great push, as you all know. It was the bigger enabler that we have seen in recent decades. So we will have more and more digital native doctors and also digital native patients that will search and seek for this kind of service. Here in Portugal, we like to see it in a three-way cycle. We call it our telehealth cycle. We have the governance aspects, the organizational aspects, and also the technology part. Of course, we start with a strategy. And thank you, Frederick, for referencing our strategic plan. I will talk briefly about that in the next slides. after the strategy has been put in place, we need incentives in terms of contracting and financing for the healthcare institutions. Also, we have a big effort in terms of organizational and care delivery aspects. In terms of infrastructure and equipment and also information systems, this is the technological part of this cycle, and it's very important. Here in Portugal, we try to establish and make available some kind of platforms so that hospitals and healthcare institutions have the means to provide healthcare and telehealth services. And then we need, as Frederick said, a good clinical governance and human resources management strategy, regulation, and also we need to push in terms of research and development strategy. Really need to push the institutions to publish their results in a way they share their use cases with everyone in the system. So our telehealth path, we can say that started in 2007. We could choose another date, but it's a good year because we launched the National Health Telephone Line, and then we had different aspects and steps that we did. But I would say that in 2016, with the creation of the National Center of Telehealth, we had a great step, because everything started to happen really fast after that, because in 2017 we launched a new and with a new vision an NHS contact center that has teletriage services and other digital services available for all citizens in Portugal. And then in 2019 we made our national strategical telehealth plan for 2019 to 2022. Last year, with the pandemic, we launched a new teleconsultation platform that we call RSC Live, which is very important because every institution, healthcare institution in Portugal, can use to provide teleconsultation between patient and healthcare provider, and also two doctors, for example, that need to talk about a patient can use this platform. And now in 2021, we are starting a deployment of an NHS telemonitoring platform that will also facilitate and democratize this aspect and this methodology of telehealth. Also, we are in process of clinical guidelines revision applicable to the telehealth services. So this is our cycle. I explained it. There is two really important aspects here in Portugal that really enable the adoption of telehealth. One is related with the funding, contracting, and reimbursement aspects, because in Portugal, when a public healthcare institution provides a teleconsultation in real time, it receives an increase of 10% in terms of reimbursement. So it's a good incentive for the healthcare institutions to provide this type of teleconsultations. And also in terms of telemonitoring, our healthcare administration has different programs that have a specific payment consigned for these type of pathologies like CPOD, post-heart stroke, and also chronic heart failure. In terms of public procurement, our institution, the Shared Services for the Ministry of Health, have an important role in terms of service procurement and autonomy, so that all the healthcare institutions in Portugal can contract in an autonomous way real-time teleconsultation services, telediagnostic and telescreening services, and also telemonitoring services. So our institution, our organization made the hard work, like selecting all the possible providers that can help institutions provide this type of services, and in a easy way, the healthcare institutions can use this service and contract these services in a simplified manner in terms of public contracting. So we have lots of different telehealth initiatives. We have some examples here, but I would like to highlight the importance of publishing the results that we have in each initiative that we launch. This is an example of one hospital here in Lisbon that recently, last year, published in a really important publication paper, a paper about non-invasive telemonitoring in patients with a specific type of heart failure. Why this is important? Because this really proves to all the ecosystem the importance of having good results and measuring the results so that we can prove the value for everyone in the system. So in terms of our national strategic telehealth plan, we have 3 strategic axes. One is broad and integration action on digital health. Also, we have a really good focus on mass adoption of telehealth services, and we promote a joint work with other sectors and entities to enable conditions for telehealth. So one important aspect is that we really care of everyone so that no one gets excluded of this type of service. Also, in the process of making this document, we conducted several interviews, around 50 interviews with different stakeholders, so that we could understand the enables and challenges that they see during this process. I will not expand much about this because you will discuss that during this workshop. But it's really important that you listen all the stakeholders in your countries so that they really pass their vision to you, and you have a good plan to address those challenges. In terms of software development, Portugal has several tech products for telehealth. It helps institutions to have, in terms of interoperability matters, and also in terms of certification matters, it's important that we have a public solution. So we have a public solution for teleconsultation, as I said before, that allows for healthcare professional teleconsultation between 2 doctors, for example, and also a doctor or any other healthcare professional with a patient. And lastly but not least, multiple healthcare providers with 1 patient. So we can have a patient here in Lisbon having a teleconsultation with a doctor in Oporto, and we would like to see, for example, another doctor abroad in another country here in the European Union providing a teleconsultation to 1 patient. In terms of telemonitoring, as I said before, we are launching an NHS monitoring platform for vital sign acquisition and care plan implementation of patients enrolled in telemonitoring programs, so that users can be remotely monitored based on measurements and self-assessment. This is going to be launched, in the next month. So we would like to share, of course, all the results that we will have in the following months. So in terms of barriers and opportunities, I would like to say that we really need to see the barriers as an opportunity. So, for example, in terms of internal processes, we really need to promote, for example, clinical guidelines, the creation of disease reference centers also for telehealth in Portugal and also abroad. And of course, in terms of location of telehealth facilities, we have an opportunity to create network and referral opportunities and networks specifically for telehealth. I think here in Portugal, we really need to push on that, and we are doing a big effort on this matter. We have a lot of incentives. I will not expand on that, you know them. So I would like just to state that in terms of the European Union Recovery Plan, we have around 300 million euros to healthcare transformation here in Portugal, that we will try to use it wisely, because we all know that just putting money in the problem doesn't solve it. We need to use the money in a wise way. Also, we need to promote sharing and collaboration between healthcare institutions, and in terms of concept, you all agree that concept agreement is key. So in terms of interoperability, this is quite important. In terms of new models of care, we really need to push them and see that there are new models, and we need to address them and take them in the front line. In terms of value, we have an important focus on having data so that we can prove the value of all our initiatives. And also we need to know that patients and all citizens in the European Union have really good freedom of choice, and it's important. It's also a challenge for everyone. It's also important to say that we have a lot of new players and new providers in the game. So it's important to take care of them and to put them into the process so that they don't get outsided and then get outsiders in this strategy. So we did a lot of different steps here in Portugal. We have a strategy, we have regulation, we have data centralized in our systems, we have teleconsultation, telemonitoring platforms. We hope to achieve interoperability standards and a common architecture, and this is important for the European context. And also we have different digital channels for the patients. We have our citizen portals, both in desktop and mobile. And we really need to push, and we try to push in terms of professional qualifications. So we already have, as you might know, the patient summary project and the e-prescription project in process with some countries here in Europe. So we really want you to start and join this journey with us. As you know, Portugal has a great weather and the big coast, so I'd like to ask you to surf with us this digital wave, and that's all. Thank you. If you have any questions, I will appreciate it.
Thank you so much, Eduardo, for the excellent session. So let's try to pop up, if we have, let's say, some question at this stage in the Menti, and you can start by taking. I think at least, I say, 3 of them are already new, at least in this the last line.
Okay. Let me check. Okay, so in terms of share of consultations done by the national platform, in fact, it was not a big share, because we have lots of security methods implemented, and the first institutions try to use or use some platforms like Microsoft Teams that don't have that much security, which it's of course a concern for us. But we are starting to address those problems and to have more simplified methods of authentication to patients, so that everyone can use our platform without different or difficulties in terms of barriers of access. Let me check. Okay, in terms of reactions of the patients using the platform, yes, we have really good feedback from our institutions, because they can even have screen sharing, they can share their exams to the healthcare professional, they have the chat, they can have more than one healthcare professional assisting this teleconsultation. So I think they have a good reaction to the platform. In terms of monitoring only the NHS hospitals, yes, of course, we have a more proximity with the NHS hospitals, but we try also to have strategies for the whole system. It's not only for the NHS system, it's for all the health system here in Portugal. Yes, it's a central initiative from the Ministry of Health in Portugal. In terms of data gathered, yes, it's shared with the patients, and it can be shared with some stakeholders, depending on the academia, for example, that is usually binded with some university hospitals in Portugal. 1 minute, thank you, Diogo. Okay, are there both private and public healthcare providers? Are they working into the same journal system? More or less. In fact, yes, there are both private and public healthcare providers. We try to push everyone and all to the citizen portal, so that the patient can have more a better experience accessing their care, but we have some silos with the private care, of course. Do you work on telehealth provided by a nurse? Yes, nurses can have telehealth consultations with patients, and also they play an important role in terms of telemonitoring. And I think my time has ended. Thank you, everyone.
Thank you so much, Duarte, for the excellent presentation. I think it was a very good overview about the current landscape in terms of Portuguese. Now we are going, let's say, to pass to the third speaker of the day, Mrs. Ana Carriazo from the Regional Ministry of Health and Families of Andalusia. And of course, we have the collaboration and the participation of Ignacio Lage, the Head of Unit for ICT Development in the Andalusia Health Services. So, Ana, now the floor is yours. Give us at least a perspective what it is Andalusia currently doing in terms of telehealth services.
Thank you, Diogo, and thank you, and good afternoon, everybody. I'm very glad that Ignacio is here with me. This is a presentation from a region, Andalusia, and we are delighted to contribute to our neighbor's presidency of the Council for this semester. So thank you very much for inviting us to provide this overview of what is Andalusia doing in the telehealth and e-health services. So if I can have the next slide. In this presentation, I will cover the general overview of Andalusia and the healthcare system, the corporate healthcare information system that we have in place, and we will detail some of our services, the telehealth service, the teleconsultation service, and some apps for citizens. And the next one, please. So just to show where we are and who we are a region in the south of Spain, all the way into the southwest of the European Union, with 8.5 million inhabitants, and with responsibility at the regional level. In Spain, we have this developing into the regions for public health and healthcare services for many years. This cross-border healthcare is also a very important issue for us, because prior to the pandemic, we were receiving more than 30 million visits, tourists from outside Andalusia, being more than 12 million from outside Spain. So this cross-border telehealth and services provided for people from other countries is an important issue for us. In Andalusia, we have a broad network of healthcare provider that is a main healthcare provider, the Andalusian Health Service, where Ignacio is working in, that covers primary healthcare with over 1,500 primary care centers, more than 50 public hospitals, all the big ones, the university ones are in the network, over 100,000 healthcare professionals, and almost 4,000 pharmacies, which are private entities, but are linked and regulated under the Andalusian system, healthcare system. We are also a reference site within the Urban Innovation Partnership on anti-healthy aging that is finishing, thanks in a great part to our e-health strategy and deployment and electronic health record. The next one, please. So Andalusia has put in place a very comprehensive e-health solution for the healthcare system, involving everything and based and centered in the patient. Everything is linked to one individual identification for the patient, with connected with a health card, and that has been put in place for over 20 years. That makes us having a lot of individual records with a lot of diagnosis, and allowing us to build a big database that is being used for the purposes at this moment. It involves primary health care, hospital care, emergencies, pharmacies who are responsible for the dispensation of the prescriptions that are done by our professionals, the whole appointment systems, the vaccines, and also images, radiology, and DAX, CT scans, and everything, and all the results assuring and ensuring the continuity of care throughout the whole system. It's a very important piece. I will say that it's like a grid, a basic tool for all healthcare professionals working in the public health system. The next one, please. So adding new additional services to what we have already put in place is the teleconsultation service. That is an asynchronous telehealth platform, the one on the store and forward, facilitating the management of referrals among and between healthcare professionals. This is focusing on the connections between healthcare professionals, and it covers referrals from primary healthcare to hospital, and also among the different specialties within the hospitals. I would like to remember and to remind everybody to comment that in primary healthcare, doctors are also specialists in family and community medicine, and it's also involving nurses with the different subspecialties that they have. So the next one, please. This teleconsultation started based on previous experiences, particularly focused on the dermatology issues with a small pilot in connecting primary healthcare with the hospital care, particularly the Macarena Hospital here in Spain. It was called eHermes prior to the pandemic in 2019. And it was expanded to the teleictus, the stroke system, with a pilot in 2 small rural areas in Osuna and Constantina within the province of Sevilla. During the last year, this connection and this referral, this teleconsultation service between primary healthcare and hospital was expanded. And it started also the hospital with different specialties, the pilot in last year. That is within this year being expanded in both senses. The next one, please. So as has been mentioned before, there are a number of professionals involved, nurses and family physicians in primary healthcare, the IT responsible, the operator, the person in charge of the information system, and also the people from the hospital, nurses, physicians, head of unit staff, and administration. It has they are all connected to combine and to support, to facilitate the transmission and the put in place of this teleconsultation within the Andalusian Health Service. So we have several circuits with different types of teleconsultation put in place. Particularly, I would like to highlight the one in primary healthcare connected to hospital care, dealing with the dermatological issues, dermatosis and skin cancer, but also for general purposes and for facilitating quick responses to family physician. Within primary hospital and hospital care, we have a general consultation service and the telestroke services, particularly and specifically. And there is also a return from hospital care to primary health care with a report on continuity of care, facilitating the continuity of care of our patients within the whole system. The next one, please. So we will see several images on how this works in primary healthcare center. They connected within the Diraya system, the corporate information system within the healthcare service. There are images sent with a brief report to the professional at the hospital of reference for that primary healthcare centers. And this image is reviewed by the professionals there, and a report is sent back to primary healthcare with the different advice, either a direct appointment or just a referral or a treatment that can be performed in primary healthcare. These images and the report is stored in the same electronic health record that is shared by the entire service. The next one, these are screenshots from the service. it's in Spanish, as you may imagine, with the report and the log and the images stored for this service. The next one are, and these images are, the inclusion of these images are facilitated with a specific app, Captura, for including the images in the whole electronic health record of the patient in the system. The next one, this is a similar circuit but within different specialties at hospital level, where professionals can refer one doctor to another specialty to make a consultation on a specific patient, and the report is stored and accessible for everybody with the correct rights to access to it and to be able to perform and to deliver the care that is needed for the patient. And the next one, this is the one that is being deployed and scaled up more recently, that is a telestroke service for taking care of people with strokes and with vascular neurologists as a referral system, and with access to the images within also the electronic health record and the Viraya system. And these are some screenshots from the system that is currently put in place. Okay, the next one. Thank you, Diogo. So some data from last year, the patients included. This was widely used during the past year of the pandemic, with almost 100,000, over 90,000 primary care patients included, and 181 in the hospital, with a number of teleconsultations requested, both at primary care and at hospital care. And the current situation in March 2021, you may remember we had over 1,500 primary healthcare centers, and it's reaching most of them. And a number of hospitals are also involved in offering solutions for 39 specialties. So the next one, what are the impacts that these teleconsultation services are having in the system? Faster referrals, facilitates the communication between primary healthcare and hospital professionals, to improve patient care and reducing waiting times, avoiding unnecessary patient travels, and improving the coordination between primary care and hospital care, facilitating a joint patient follow-up, and a care continuity from primary care and hospital care. And also very important is to mention that the IT support for stroke management relies within the Andalusian plan, comprehensive plan for stroke. And my previous to the last is the services for the citizens that we have just recently launched with an app called Salud Andalucía, means Health Andalusia, that involves not only the previous services that we have, that Click Salud was the patient portal to the electronic health record, but it also includes the foreseen digital certification for the vaccination that is there already, that my colleague Ignacio is very proud of, and also the other apps connected with the entire system that are available for specific purposes, and that can allow a communication from patients to healthcare professionals in the system. And from my side, muito obrigada. Thank you very much for this opportunity.
Thank you so much, Anna. And sorry, let's say, for always, let's say, to be a little bit, let's say, controller with the time, but it was, let's say, an excellent overview. I think we are, let's say, this similar roads that we are taking, at least this in overall perspective, to really to have the citizen in the center. So just 3 or 4 minutes for some questions for you that you have in the screen, if you'd like, let's say, to take some of them.
Referrals, I will start with this one on if referrals there. We already have the referrals included in the corporate system, but this is a teleconsultation that is more directly with a fast response. So most of the referrals currently done within the system are already stored, but it goes with the patient. This teleconsultation facilitates and speed up the response from professionals without the patient having to go or to travel and to, if not needed. If it is needed, it's not. There is also some referrals that are made by paper, but it's very residual. Most of the referrals are within the system. Can patient access the data in the EHR database in Andalusia? Yes, through a secure online access with digital certificate. You can access Click Salud and selection and a summary of your report. You can access your appointments, your diagnosis, the treatment, that medication is, we have a single repository database for medications in Andalusia, your images, and you can share it and you can access them from the mobile as well. Does this network also include some special fields like digital pathology? Okay, digital pathology, the very important issue. There is a pilot or a specific unit working on this digital pathology, but it has a very strong request of servers and infrastructure that we are currently working on that. But yes, there is a line of work while dealing with digital pathology. It's not completely spread. Digital radiology and all the radiology, density, and X-rays are in the packs and accessible, but pathology has a specific issue. Do the expats take up the survey or the regulatory back to the home country? I don't understand this question. Sorry about this. How the patient is access to the mobile app in Andalusia? You can download the app and you can access through secure access to the information that is stored in Diraya with a digital certification or the national ID or the different certificates that are available in Spain, the Clave. I'm sorry about that. We will try to reply and to contribute to the discussion later. Diogo, Ignacio, thank you.
Thank you so much, Anna and Ignacio, for all the collaboration on this specific activity. I'm really delighted to have you here on the board, and of course, I believe, let's say, some of your experience would be very valuable for the brainstorming session in the next part of the session. So right away, we would like, let's say, to change for Mr. Martin Whitehead. That is representing is a regional clinical advisor and consulting for the stroke division as NHS Lanarkshire. Please, I am really delighted to have you in this session. Behind the you, of course, for us it is still a kind of to have you involved or outside, but I'm really delighted to have you participating with us today.
Thank you very much. And I think the first statement I should make is actually I'm sorry that we've left the EU, but we'll have to leave that one at that. Thanks very much for the invite as well. To say that this was a surprise that would be a real understatement. Before I start, I've got to say thanks to Anna Ranta, who I worked very closely with, the consultant in New Zealand, and also, although she's not written there, Anne Rioch, who at the time was working with the Scottish Centre for Telehealth. And without those two, this project wouldn't have got anywhere. So thanks for the invitation. And I'd like to just tell you a bit about how we managed to prove that the concept of an international telestroke service was indeed possible. Could we go to the next slide, please? Thank you. Just to give you a little bit of background about stroke, it's a very expensive thing, both in financial costs, but also in personal costs. About 80% of people who suffer with a stroke, it's due to a blockage in a blood vessel. And we live in very fortunate times in that if somebody can get themselves to a hospital within 4.5 hours, there's a chance that we can treat that stroke. The idea being that we're able to break down the blockage and restore the blood flow back to the brain. what we're aiming for really is to keep your brain looking like that slide on the left and stop it turning into something similar to the one on the right. Once a blood vessel's been blocked, we tend to lose about 2 million brain cells per minute. The quicker, therefore, we're able to increase the perfusion back to the brain by removing the thrombus and dissolving that, the better the chances of the patient surviving and the less likelihood of them living with significant disability. Next slide, please. At the moment, we need to treat people within 4.5 hours from onset of the stroke symptoms. So for every 100 people that we treat with thrombolysis, we would expect an improvement in about 49 out of every 100. In about 45 patients, it doesn't make any difference. And unfortunately, in about 6 in every 100 patients we treat, they deteriorate because they have bleeding associated with that treatment. 1 in 100 patients that we treat will die as a result of the increased bleeding risk. Next slide, please. A bit of background of where we were in Lanarkshire. In 2009, we were thrombolysing roughly 6 patients a year, and that's a population of 600,000 individuals, about 1,000 of whom would present with a stroke each year. That means that we should have been treating about 100 to 150 per year with thrombolytic therapy. We were treating 6. We knew we needed to do something, but we were split across 3 acute sites and we had very few staff. The only way we could do that was utilising telemedicine. We therefore implemented the first mesh telestroke system in the UK. We were able to improve that over time, but we could never get ourselves into a situation where we were able to work 24/7. That meant that we were always going to be missing some patients, and some patients were going to be coming to harm because of that. Way back in 2011, I was very fortunate to have conversations with Anna in New Zealand, and we decided that we needed to chase the sun. The idea was that the consultant who was awake during daytime would treat not only the patients in their own area, but also the patients from the night time on the other side of the world. Whilst in Scotland, we were making good progress with telemedicine, in New Zealand, they were just at the very early stages of both discussion and also some early stages of development. Sorry, next slide, please. At the time, we didn't call them barriers, we called them hurdles. We knew that we were going to be able to overcome whatever was thrown at us, but we also knew that some of these hurdles were going to be a lot higher than others. At the time, technology was the first thing that we felt was going to be a bit of a problem. We needed to have rapid, reliable access to good quality CT scans. We needed to ensure that we weren't going to risk harming patients. We needed to have a look at a CT scan before we were able to offer treatments. We also needed to have good video consultation platform. It had to be stable and secure, and it had to be exceedingly reliable. There were the obvious legal issues, working in between not only different health boards, but different countries. Perhaps one of the concerns that we had that was the least justified out of all of them was whether the patients would actually accept being treated by a foreign doctor from the other side of the world on the end of a TV set. We knew there were going to be governance issues. There always is in any new development of any service. That wasn't a great surprise for us, and we had that in hand as far as we were concerned. Next slide, please. We'd certainly anticipated that clinicians would be on board, both in New Zealand and in Scotland. There'd been lots of enthusiasm as we were developing the service in Scotland, and understandably, the consultants in New Zealand were keen to be able to provide a full service for their own patients. As clinicians, we also knew that there would be benefits for our patients because they were all going to receive the optimal care that was available at the time. And we also felt that we're actually going to be quite fortunate as clinicians because the chances of us being woken up at 3 o'clock in the morning to make important emergency decisions was going to be minimised. We also expected it to be a fairly straightforward discussion with management within the health service. It was obvious that we were going to get improved patient outcomes, which would reduce patient costs and lengths of stay in very valuable hospital beds. But there's also going to be a reduction in the costs of the clinicians themselves, as they wouldn't need to be involved in intensive overnight rotas, and you get much more efficient clinical behaviour during the daytime. Tired, sleepy doctors tend to make mistakes and tend to be a little bit slower. So it's quite a surprise when we came to spend the next 2 years trying desperately hard to get a service up and running. We were extremely surprised to find clinicians in Scotland were pretty reluctant to be involved in any level. Whereas at the opposite end of the scale in New Zealand, very optimistic and very positive. The IT guys, both in Scotland and New Zealand, were very enthusiastic, and technology was really no problem. It was ironic, really, that the positive media coverage in New Zealand prompted negative media coverage in Scotland, which seemed to be taken on board by both politicians and also NHS managers in Scotland. On the other side of things, with the positive media coverage in New Zealand, they were very enthusiastic within the management structure in the local health services in New Zealand. It was also a little surprising to find that despite this at the sort of middle level in Scotland, that the health department in Scotland were very supportive, as they were in New Zealand. Next slide, please. All consultants who are involved in any direct care need to be protected legally, and the Medical Protection Society were more than willing to provide us with that insurance policy. They cover doctors throughout the world, and actually had a base in Palmerston North, which is the hospital that I was working with at the time. Legally, we come up against some what turned out to be hurdles and barriers that were insurmountable at the time. In Scotland, we couldn't really get anywhere with the legal side of things. They weren't willing to take very much risk at all, whereas in New Zealand, although I wasn't going to be treating patients, they agreed that because I was providing advice that this was not going to be a problem. It did mean, however, that there was no opportunity for any reciprocal service to be developed, and that the whole of the service now had to be one way, with me providing input and assessment for New Zealand patients. Again, without the Scottish Centre for Telehealth and Telecare, who had lots of experience through multiple telemedicine projects in Scotland, we wouldn't have been able to progress things. We were well supported by the medical councils, both in the UK and New Zealand, and the data sharing agreement with New Zealand was very straightforward. Next slide, please. So we ended up with a service being provided, one direction, 9 AM to 10 PM UK time, covering the night time in Palmerston North in central New Zealand. All patients were consented prior to assessment, and there was a rigorous governance process that was taken on board. We made sure that we got feedback from all people involved, patients, relatives, and also all of the staff in the EDs in New Zealand. Next slide, please. We were able to successfully assess 8 patients, 3 of whom were treated, which is about average when you consider that normally you would be treating about 50% of the patients you assess in an acute stroke situation. No issues with technology, other than one time when a person had turned the machine off and couldn't find the on-off button to put it back on. Next slide, please. So we have to admit that our anticipated barriers and enablers were generally misguided. We thought that the people side of things was going to be straightforward, and the technological side of things was going to be very complex. It turned out to be anything but it did give us a lot of hope, and it has certainly helped progress telemedicine and telestroke in particular across New Zealand, which in many ways now is rapidly overtaking the great telemedicine work we do in Scotland. Thank you.
Thank you so much, Martin, for this overview. And I think you have really touched upon that. One thing is one on labor, and the second aspect is, of course, the challenge in this way. How can we overcome it in a short period of time? And I think this is exactly one of the use cases that we saw really an advantage to bring you today, for you to see that at this point in time, the national activities of telehealth services are very related, or at least can be foreseen on these cross-border use. I think on my side, it was very insightful, your contribution. If you want, you can answer to some of the questions that we do have right away on the screen, and then we'll pass to the next speaker.
Okay. Unfortunately, the project's not still ongoing. I've spoken to Anna last week, actually, or a couple of weeks ago, and there is the possibility that we will consider restarting the service. But as you mentioned there in the question regarding the extraction of clots, because that is something that we're trying desperately hard to get off the ground in Scotland at the moment. There are a lot of changes likely to happen in the hyperacute situation regarding stroke care for patients. It obviously does mean that it would be a lot harder to do telemedicine when it comes to taking a clot out of somebody's intracerebral vessels. Although there is someone who I believe is working on that at the moment in Scotland and trying to get a robot that they can operate from Edinburgh to Aberdeen. So is that one for me? What types of incentives for healthcare professionals and health units? Or is that from the previous, sorry?
I believe it's for you.
I think this is I think in this case it is for you. You can have taken and then you can move. I think it is
right, that one. Okay, so I think the incentives for healthcare professionals really is you're going to be providing the optimum care for the patients. I think on balance, even if at the time we hadn't needed to restructure our service, if you think about how well you're able to function in the middle of the night when you're woken up at 3 or 4 o'clock from a deep sleep, it isn't as good as it is in the middle of the daytime, and there's lots of data and evidence around to show that. So from a clinician point of view, it is sometimes a little bit disturbing that you may or may not be making the right decision in a highly pressured situation. That would be the main incentive for us. How is Brexit influencing your initiative? Brexit seems to be influencing everything in a negative manner at the moment, but I wouldn't want to get too political. It's very strange seeing me giving a perspective from outside the EU. It makes it quite difficult at the moment.
So thank you so much, Martin, for the accurate answer to all the questions. It was, let's say, very insightful, and really to see that at this point in time, there is already initiatives ongoing for these cross-border telehealth services. Thank you so much for that. So we are right away passing to the next participant. So Mr. Krishnan Ganapi. And I'm right away would like, let's say, to pass to you the floor. We're a little bit behind the schedule, but you can continue your time because we are going, let's say, to at least to adjust a little bit on the discussion and on the brainstorming session. You are still muted, Krishnan? Okay. Great.
Yeah. Sorry, I seem to have some problem with my... can you let me share the screen, please?
You should be able
to. Okay, are you able to see it now?
Yes.
Yes, just put it in the full screen and then it is right open.
Yeah, are you able to see it now?
Great.
Okay, you are able to hear me also?
Yes, the sound,
okay.
It is good.
Thank you. First of all, I thank the organizers for giving me this opportunity. Though this is not strictly a cross-border telehealth service, considering that I'm going to share my experiences with you on how we deliver health care 2,000 miles away, I think it's as good as a cross-border illustration. Now, I'm going to confine my myself to public-private partnerships where state governments and the government of India has outsourced healthcare to private organizations. I represent the Apollo Hospitals Group, the world's third largest healthcare provider and the largest in Asia. As you can see, we run mega projects all over India, and the one I'm going to talk to you about is mainly in the Himalayas at a height of 14,500 feet. A couple of weeks ago, we published a full chapter in a textbook which came from Europe. If anybody is interested, I'd be happy to share this. A 33-page article on technology-enabled remote healthcare in a public-private partnership mode. These photographs speak for themselves, and I have been here twice. I have a wonderful staff, and this staff is the one who is doing all this entire work. You can see here, the most important thing is that this is the place, this is how this district in the Himalayas was before we took over. And over the last 4 years, we have been providing them health care. The major reason for our success is the minute attention to details. We identified people from the local community, brought them to Madras, 2,000 miles away, kept them 3 months for us in a quaternary state-of-the-art JCI accredited hospital, trained them completely. I also trained my consultants, most of whom are worked in Western countries for 10 to 15 years, who are all accustomed to state-of-the-art treatment. So we had to train our consultants to tell them how to manage patients in situations where you just do not have an MRI, for example. The other reason for our success is my staff went physically to every single house in this district, 34,000 population, minus 25 degrees temperature, landslides blocked all roads for 5 months in a year, and we ensured that every single citizen in this district knew about telehealth. Just to give you 1 or 2 examples, over the last 5 years, we have been able to identify 12 patients with myocardial infarction as they were evolving. My staff, 2,000 miles away, were not satisfied with the first ECG, even though the first ECG was normal. They said, I just don't like the look of this patient, and let me repeat the ECG. And we asked the paramedic on the other side to repeat the ECG. 45 minutes later, the second ECG showed ST elevation, and we initiated thrombolysis from a distance of 2,000 miles. We have done this in more than 15 patients so far. Several papers have been published on telemedicine in the Himalayas, operational challenges. To the best of my knowledge, this is the only 24/7 tele-emergency services which is successfully functioning for more than 4.5 years. We have treated 1,500 people, including patients with supraventricular tachycardia and various other conditions, using state-of-the-art telespirometry and so on. Now, just to give you a couple more examples, so on the top right-hand side, you see a telehealth center in a very disturbed area, just 20 kilometers away from China, the Indo-China border, where doctors are just not willing to go there. It is a very disturbed area, and we have set a telemedicine unit there. At the bottom, you see India's biggest state called Uttar Pradesh. The population is equal to that of the European Union. And 2 years ago, the government requested us to provide them with teleradiology services. And you see it, of course, this was before the COVID pandemic came. And you see a major part of our success for teleradiology was the intense training we gave to the teleradiology facilitators. On the top left, you see promoting health literacy. We very strongly believe that telemedicine is not just diagnosis and treatment. We take proactive measures, and we believe that patient empowerment, knowledge empowerment is very, very critical. And using multi-point video conferencing, every week we hold informative programs in the local language where hundreds of people from villages attend. So training, retraining, learning, unlearning, these are very, very critical. We are very happy that over the last couple of years, we have successfully delivered digital healthcare. We are almost paperless. This is on real time. This is a screenshot which I took just day before yesterday. I could have taken it even half an hour earlier, and you can see this is updated in real time. This is totally transparent. Of course, you need a password to access this, but the government and the provider, namely the Apollo hospitals, all of us have access to it. This is updated in real time, an extremely detailed dashboard which everyone has access to. This is another state in India called Jharkhand, a very, very backward, one of the most backward states in the country. And here also, we have been providing them with digital healthcare over the last 2 years. We have done a proof of concept validation where 100 digital dispensaries. My staff man all these dispensaries, and again, this project has been very, very successful. On our own, though this was not in the contract, still to make it totally transparent, we initiated the process of providing monthly reports, and every month we send a detailed report to the government telling them exactly what was done. This slide shows what I think is the world's largest public-private partnership in teleophthalmology. Even during the period of intense lockdown, we were able to operate 10% of the services. Now we have come back to our normal work. So 115 vision centers in the neighboring state, about 300 miles away. These people are evaluated by 30 ophthalmologists in Chennai, where I live, originally known as Madras, the third largest city in India with a population of 14 million. And as you can see, we have done more than 400,000 fundus examinations remotely. And believe it or not, within 15 minutes, a villager gets an annotated color printout, signed digital signature of a retinal specialist or an ophthalmologist who gives the entire report within 15 minutes. For the patient, this is totally free. The government, of course, subsidizes it, and we do this on a non-profit, no profit, no loss venture. These numbers are staggering, but this is the true picture in India. You can see 12 million consultations have been given in this hybrid model, and specialist teleconsultations alone have reached 1 million. Today, the Apollo hospitals gives 10,000 on an average, 10,000 to 11,000 teleconsultations every single working day. And we have completed 13 million teleconsultations. This is a project provided by a multinational company who funded this. Unfortunately, after the COVID pandemic, we had to stop this, where we provided camps. We were screening people for NCDs, particularly for diabetes, hypertension, obesity, and so on. And with a screening camp, teleconsultation was available even on-site at the screening camp. I will now come to the last part of my talk, which is what I was specifically asked to stress by the organizers. I've only given you a few samples. What is much more important is sharing the lessons which we have learned, what is not taught in Harvard Business School or the London School of Economics. This has been learned from my staff, a very, very passionate team of street smart people. Please remember that I'm a neurosurgeon who got interested in telemedicine 20 years ago. We do not have MBAs, we do not have professional healthcare administrators, but every member of the team are passionate about telemedicine. And this is what we studied, we learned. A detailed need assessment is the first step. Risks in implementing the program, necessity for retraining, unlearning is extremely important. And of course, we very strongly believe that all people, no matter where they live, have a right to access high quality, affordable care. What are the management concerns in deploying telehealth? 90% of telehealth projects, this is a literature survey done over the world. Of course, this was true until a few years ago, do not succeed. It is less than 10% which are revenue generating, self-sustaining, and more important, are actually scalable. And how did we achieve that? We did it by being future ready, access to cost-effective, need-based, appropriate technology. We ensured that we had a dependable and robust telecommunication network. Most important, we always took into account what the patient wanted. So patient perspectives of telehealth quality. We never imposed anything from above, but always took what our beneficiaries wanted, and feedback was the single most important thing. Over the last 2 years, legal, regulatory, security issues have also come up, and these are being complied with, compliance and adherence. Of course, a major cultural transformation had to be effected for them to accept technology-enabled remote healthcare. And equally important, as I've already mentioned, the urban teleconsultants need to be sensitized for community interaction when they're deploying cutting-edge technology, which is not available in the towns and villages of India. Finally, ladies and gentlemen, opportunities need to be identified to initiate telehealth activities, implementation challenges, and specific strategies during the pandemics. A single strand of RNA has acted as global CTO, Chief Transformation Officer. The government of India, because of the pandemic, notified the telemedicine practice guidelines, and telehealth has grown and at an astronomical rate of almost 15 times of what it was before COVID-19. And most of us strongly believe that telehealth in India is here to stay, and even after the pandemic is denotified, which I hope will happen not too late, even then telehealth is here to stay. So, thou shalt digitally transform. This is the message which a good part of Indian healthcare industry is now accepting. You can ignore reality, but you cannot ignore the consequences of ignoring reality. So I would be very happy to take any questions. And of course, unfortunately, there is no time. Otherwise, we would have been happy to share with you our experiences on how India is today offering healthcare to the rest of the world.
Thank you so much, Professor Krishnan. I was still astonishing on the amount of data and the amount of effort that you put to it. So I think for the purpose, I will let's say, at least for you to have, let's say, 3 or 4 minutes of questions, let's say, for answer these two that are in the screen, because you more than anyone deserve it, because if a country, if an initiative touch in Himalayas, I think this is like you have said, if we do that, it is possible to do it across border. So these are the 2 questions in the screen. As the COVID-19 impacted telehealth services in the Himalayas, and the second one is, what would be the next most important improvement of the system, tech, legal, or another topic?
Okay, luckily the COVID-19 has really not had a major effect in the Himalayas, particularly our telehealth center. So we are continuing that. That is the answer to your question. The other question, the next important improvement of the system, I don't think technology is a problem at all. Neither is legal issues or regulatory issues. The most important thing is what I use a phrase called YFM, WIIFM. In other words, what is in it for me? So this is the most important question to be addressed. Every single member of the ecosystem must have something. There has to be an incentive, a disincentive. It need not necessarily be monetary, but there has to be a business model. Unless there is a return on investment, philanthropy at the best can start a telemedicine project, but it cannot maintain it. This is what we have been advocating for the last 20 years, and therefore there has to be a business model. Somebody has to meet the expenses. It could be the insurance company, it could be the government, it could be out-of-pocket expenses directly from the individual. So according to me, that is the single most important question to be addressed.
So I think for the time being, I think sorry for don't let you let's say to have more questions, because I would really like, let's say, for you to answer the rest. So of course at this stage, thank you so much for your vision. Please stay with us until the end of the session, because I really believe that in terms of the brainstorming exercise, you have a lot of knowledge, like the rest of the colleagues that are participating on today's session. But it was a very inspirational talk by you. Thank you so much for participating in this workshop, Professor Grishman. So
thank you.
In terms for the coffee break, it says, let's say 10 minutes. We are I think it's, let's say, more or less 18 minutes behind the schedule, and I want, let's say, to try to close as much possible near the time frame that we have set. So let's make use only 5. So we'll convey at 2:45 more or less. In this case, 3:45 Central European time for the brainstorming exercise. So please take a coffee or take a cookie or a cup of tea, just for us to stretch a little bit our legs, because after 1 hour and 15 of session, I think we more than deserve. So in 6 minutes, we will convey once again. Thank you so much.
So,
இன்னும் முடியலமா, one more session. இல்ல சரியா இருக்கு.
So good afternoon once again. I think we are going, let's say, to start already the brainstorm session. As I have written it down on the chat, for the following 45 minutes to 1 hour, let's see how much can we adjust this brainstorming session. Please, you may need to use, let's say, your browser in your laptop or your mobile phone. We'll try to be a little bit of interactive in this session. You can intervene by speaking, or you may use, let's say, this specific session. We want, let's say, for this part to be as much informal as possible, and of course, for us to contribute together on what are the main challenges and the enablers for these cross-border telehealth services. In terms of the main objectives, next slide, that we do have for these specific sections are three. So the question that I would like for you to frame at this point in time are the following. How do you envision a cross-border telehealth services in the EU? What are the barriers needed to be addressed, and what enablers needs to be strengthened? For the countries that are outside of the EU, of course, how do you envisage the cross-border telehealth services outside of your country? So this is the reality. So right away, I'm going, let's say, to pass the floor to Vanessa, that she's going to give us an overview how we are going, let's say, to do this exercise together with some concrete practicalities, and of course myself with her are going, let's say, to make the moderation and the facilitation of this specific session. Vanessa, to you.
So hi everyone. We're going to start with just a warm-up exercise. So again, to the Menti, which exactly Miguel already posted. And we want you to try to think what service come to mind when thinking about telehealth. And I'm going to change to the Menti for you to see. And this is like a word cloud exercise. So we basically want to see telehealth for you. What does it entails? What does it? What service it comes to mind when you think about it? So have a moment to. Okay, we have remote already. So let's see how this comes. Do you think about concrete services? Okay, quality of care, convenience, of course.
I think this will be, let's say, very dynamic in terms of what will be, let's say, the kind of the main focus. Now I think are going, let's say, to see technology, the patient empowerment, and of course the quality of care as a good initiative. So this is just some warm up to break the ice with all of you, and of course we want, let's say, for you to be comfortable as much as possible. We are not request, let's say, for all the 80 participants to fulfill it. So we want, let's say, to have, let's say, just 1 minute to be in this exercise, just for us to at least to stretch our fingers. So I do see, let's say, flexibility and access, a very good dimension, because like we have shown in the previous session, to make these telehealth services available everywhere in a country and across borders, it is a very important initiative. So it is, how can we make that on the flexible way? We are not only seeing topics such as teleconsultation, but as well tele-rehab or rehabilitation monitoring. So I think this is a lot of different perspectives that we do have today in the audience. So let's stay 10 more seconds. At least the patient empowerment seems, let's say, the big buzzword here in terms of the what comes to our mind when we think about, let's say, telehealth services. Let's try to hit the 30s, and then we will move to really to the tool that we are going to use. So, yep. Just one small game that we still before we jump. So Vanessa, I think we can move to the next part and just explain. You don't need, let's say, to change platform. This is going to be exactly the same. So Vanessa, tell us a little bit what we are going to do.
So first, before even the brainstorming session itself, we wanted to know if you agree with the definition of telehealth, because sometimes it feels like, for example, telemedicine and telehealth can be used indistinguished, but are they the same? So we took this definition for the JSON, which says that the telehealth is a subset of e-health and comprehends the delivery of healthcare service by healthcare professionals where distance is a critical factor through the use of ICT to provide clinical and non-clinical services. And it distinguished from telehealth in the sense that it focused on more, in the sense that telemedicine focused more on the curative scope of the healthcare services and excludes more the preventive and promotive aspects of healthcare. So going back to Menti, do you agree with this definition? Do you do not agree at all? Or wait just a moment. Okay. Or do you agree partially with it? So this is a different way to show the results. So we'll start and we'll have your voting for this definition. Okay, let's see.
Of course, this is not a game itself. It was, let's say, the way that we try, let's say, to be as much fast as interactive as possible. But in the end, just I know that it's very good just for us, let's say, to train a little bit our speed and what we provide. So everything it is wrong, because at this stage we don't have a common definition for telehealth. So this is one of the baselines and one of the initiatives that we want, let's say, to build under our presidency, or at least to start having a common mindset about it when we think about, let's say, cross-border teleconsultation. So having said this, now we are going, let's say, to start a brainstorming exercise and really to go in terms of the cross-border telehealth services. And what I want, let's say, for you to be focused on, it is really to have this mapping on the barriers and on the enablers, based on the fact that we have divided these barriers and enablers in 6 main areas. In terms of the legal and regulatory, organizational, public administration, technical, finance, clinical, cultural, and of course, in this having said, this is going to be at least the cluster of information that we have. Vanessa, can you tell us a little bit how are you going to use this tool?
Yeah, of course. So Savava, as Miguel already put on the chat, you can go to the website, and then we have this more purple side where you can enter the code, and I will show you now the screen with it. Just a moment. Okay, so you're getting everyone on board. when you have a doctor's voice, apparently. So I'll just move to the next slide just to give you an idea how this will play. So basically, we will explain you first what are the questions, which will be barriers and enablers, and we'll have a phase of contribution where you can put your inputs, and we'll give like about 50 minutes for this part. And then we'll move to a cluster phase, which is basically putting together, because the same idea can be put in different wordings, so we'll try to cluster that, and we'll have like a 20-minute session because this can lead to a good discussion. And then we'll have a fun part of voting, which we'll try to, okay, these are the ones that need to be addressed right now for us to move forward. So I'll move to the next one. And this is, as mentioned, we have divided the barriers and enablers, and we're seeing barriers or hurdles, as Dr. Martin explained, as they are hindering the application of the cross-border service. And the enablers, I mean, are the facilitators, which sometimes are not perfect, but they're already moving the path towards it. So we have the 6 areas which have already been explained, and I'll go to the contribution phase. And here, as it, oops, sorry. Okay, so you can see, okay, you can see the barriers first and enablers, and then if you press in one, okay, maybe here, and then you can just post your ideas about it. For example, barriers for legal regulatory, and you can simply write an idea. So we'll give you a time to think about. I think the presentations today have for sure talk about some hurdles and enablers that have been some already been faced and are great practice, and others will still need to be addressed. And we'll wait for you to play around with the platform, which is quite intuitive, and start putting your inputs on it.
So at this stage, you may use, let's say, wherever you want. You can start, let's say, from the legal. You can start for the enabler. So this is upon you wish or upon you decide. So please try to fulfill that. So I will try, let's say, to moderate a little bit and to give some insights with Vanessa and with Miguel here about, let's say, the different topics that we do have in mind. But you don't need to follow. You just need, let's say, to give inputs to the areas where you do feel more comfortable. So in terms of the legal and regulatory barriers, tell me a little bit, Vanessa. I think at this stage, in terms of uncertainty, at least in my perspective, there is a lack of clear rules for liability and jurisdiction. And this occurs for national and, of course, for cross-border level. At least this is one of the dimensions that when I see legal and regulatory as a kind of one important dimensions to uptake, where, for example, member states do not provide clear rules about the liability in their legal frameworks. And of course, how can this will influence the healthcare professional willingness to use telehealth services due to the risk of possible damage to the patient in the remote or spiritual health. So in a way, this is at least my perception. Do you have any other view?
Yeah, I was actually thinking as not as SPMS, but as someone that has a healthcare background, this will definitely influence the willingness to prescribe, because a physician, let's say, may be afraid, okay, I'm not certain if there's a harm for my patient. And it's not even healthcare professions. We have IT, technology, and there's a multiplicity of stakeholders that need to be taken into account. And not having a clear rule or framework that guides that can be quite a barrier to facilitate the introducing of this service, not only across border level, but even national level. But I think at the same time, we actually heard some very good practice today. For example, the Scotland, New Zealand example, that they were able to pass on that. There were 2 different countries that understood correctly what will be the responsibilities, and since it was a medical advice, I mean, and I think that was a really good way to maneuver this, and that's something that to be taken into account. And I think that actually could be like an enabler, and maybe I'll be the one giving like a contribution here as well. Oops, how do I do this? So I think so. And I think maybe moving on to other questions in the legal one is authentication, right? How can we make sure that that is the citizen and that's the healthcare professional? Because that will be for sure something that to make a very trustworthy system, we have to have the framework to guide that. What do you think about Diogo?
I think that is a very important uptake that you have mentioned in terms of the authenticity and how it is really the healthcare provider. But this looks like a kind of a second dimension. Now that in Europe we do have, let's say, the GDPR. And of course, it is very important for us to understand, let's say, two different dimensions. The first of all, it is how data it is processing, stored, and the security of it. So I think this is, in a way, it can be the legal and regulatory, but as well on the technical and organizational. So for me, this is a most of a cross sectorial kind of barrier, or at least topic to be understood. And a second dimension, it is where we start this initiative, and it is the health data sharing between different countries, between different regions, and between different healthcare authorities. I think this is the stand ground and one of the pillars to why telehealth services will be a feature on top of the existing initiatives on the data sharing between the different providers. So I think at this stage, one important uptake is, of course, on the ownership of the data. And now it is processed by the healthcare providers, by doctors, and by other stakeholders. For example, the ones that control, or let's say, the financial ruler uptakes. So this is one of the topics. I don't know. How do you see, for example, that we need, let's say, to do in terms of the controlling mechanisms, the fraud? What is your view, Vanessa?
For sure, something that the countries will be willing to look at it, because that will for sure influence not only the beginning, but the sustainability of the healthcare service at the long run. Because how can we ensure that at the cross-border level, this is not being used, for example, because I just don't have that service in my country, and I feel like that service can be provided better in another country. And how can we actually make the service to be transparent and trustworthy, and how can member states collaborate for that to be a reality, and even other countries with each other. And I think that will be for sure something that needs to exist to make this sustainable on the long run. And taking on that, in the trustworthy, I think the qualifications and the mutual recognition of the professional qualification is also something to be really think about it. There have been steps, and we have some work and directives towards that, but I feel like while the path has been built, we are not there yet. And for the cross-border level, we actually need to take a look at it. And I think also as an enabler, the work with the European Skills, Competence and Qualification Occupation project is also very important, which is mostly standards and a terminology that will facilitate that. But I feel like there's also more work for it. What do you feel, Diogo?
So I think in terms of the legal and regulatory framework, I think we have already discussed, but I would be very, very interested really to see what is the current kind of uptakes that we do have in all of these dimensions. But I think we are going, let's say, to uptake that in the next part of the session. So I don't know, because this is going to be kind of still a kind of a conversation between you and I. There is any other colleague that would like at this stage to intervene? Of course, we are going to request your intervention in the next part of the session, but would like, let's say, to break the ice here and to see some of your topics, or at least that you would like, let's say, to say something to the audience. Okay. This is always where the difficulty is, let's say, to use this online tool where it is more easier for you to type, of course, in different hubs to ship in. So I'm still thinking that in terms of the clinical side, we are still lacking a little bit behind and on the financial. So at least I would like to say to hear a little bit more about some of your points about, for example, in the case of Portugal, we saw Duarte saying that there is a majority in terms of the reimbursement that the government uptakes. I think this is a good thing, but in the end, there are some other schemes that will be important to understand in terms of no clear framework to support the social security provides to the telehealth services, in specifically to the cross-border level. So it is very important how can health will be connected to the social aspects. I don't know, and of course this will make a strong liaison in terms of the financial burden of the initial investment on telemedicine. In this case, to have upfront costs in all the infrastructure, all the governance behind of these specific type of services. So I don't know. Any other colleague would like to uptake, or at least Vanessa, what do you think would be some supportive mechanisms that we do have as enablers on this section of the financial?
So great point. We have some work done. We're not starting from point zero. We have some directives already giving a framework for social security coordination. I think having clear use cases or understanding what will be the cases that healthcare at the cross-border level should be supported will help to promote its adoption, because you have a clear understanding why should this be financed, right? And taking even on that, the evidence, right? Because while there are some studies, there's others that still there's like a lack of very clear added value and evidence to prove it. And as Duarte also mentioned, it's very important to actually report and show that the benefits of the different telehealth services, and we're not talking only telemedicine, we're talking about remote monitoring, and having that will definitely help to move forward. And I don't know if someone wants to talk. Dr. Warsha would like to talk. Okay, just the sound. I feel like even the evidence also connects with the clinical area at that way, because that will also help healthcare professionals and citizens understand, okay, this actually is a good service for me, will bring quality of care for me. And I think this should definitely will help and facilitate the cross-border telehealth. What do you think, Diogo? Or anyone wants to intervene? You can actually ask on the chat if you want to intervene as well.
Would like to, of course, we can always talk a little bit. I know that at least I saw one colleague here from Portugal that who was popping up the mic. If you want, let's say, to take the floor, Rafael, please.
Hello, thank you very much for this presentation, for this workshop. It's grateful to see what's happening here and all the ideas that are putting in together. For me, I will try to bring some thought. In cross-border telehealth services, I only imagine it can occur because the patient needs or the health team needs. So in some cases, the clinical don't have that barrier, because if it needs to contact another colleague in other country to better serve the patient that is in his side, they do it. They don't borrow with the financial or something. And if he needs, he contact and put all the network that he knows to the benefit of the patient. So, but to do it in one way, in what for one patient, doesn't solve all the possibility, and don't bring all the benefits that can bring to this discussion. So I think that more that the will of clinicians, we really need to work on, if we see this cross-border telehealth services on a social matter, or in a social pillar, or we will see in a single market pillar. So in single market way. this diverges because all the financial things can be different if we see one side or the other. But probably the first question, the first discussion, concepts probably. The second one is we see this as a need to answer to some patients, or we see this as a need to some new ways of the users or the patients want to have their health. So there's two ways. I think it's after the concepts we need to look at which way that we're going to see the cross-border telehealth services.
Thank you so much, Rafael. I think this was a very good overview about some of the barriers that we have identified here. So maybe we can start already, let's say, shorten a little bit, let's say, the brainstorming session, and we can come back to the second part about, let's say, what have we found from this first exercise in all these sections. And of course, I will be delighted to have your contribution, at least, let's say, some of your comments on what we have found. So, Vanessa, please, can you pass to the clustering, or at least to identify what will be the clusters of these informations? So what do you want for us to do?
This should be changing, it's not changing. Okay, so now we're going to open one by one and take a look at it and try to see if they are similar or not so much, and we can actually connect the different ideas. So I just opened the barriers to legal and regulatory, and we can take a look at them and see. I mean, there are great discussions here. Okay, for sure, yeah, not having a standardized or at least a common framework to help the cross-border healthcare, and definitely is important. The clear rules for liability. And please go ahead, everyone. You can turn your mic and contribute and have a discussion on these. These definitely, I believe, how to overcome fragmentation among national, regional health institutions can connect with this one. So if you agree with me, I'll just cluster these two and let this one together. Then we have the authentication. Fear of litigation for sure connects with the one that I just saw here. I hope you agree with me. If not, please turn your camera, put it on chat or turn your mic. Then we have the sharing data for sure, authentication, medical license, and professional qualification. We can put them together. And I think, please, Diogo and Miguel, if you see something that I'm missing, do let me know.
So I don't know what the rest of the colleagues are seeing at this stage. So this is more or less, let's say, of the exercise, and then we will vote for these priorities. I know that this is still a little bit in rush, but at least on my side, I think it is very important for us to start clustering, let's say, on the barriers, at least to identify. So in terms of the organizational, so for sure that there is a need to work and to understand what are the clinical protocols and to don't work in silos. And of course, what will be the different understanding from two different departments, two different specialities, two different organizations, two different cultural organizations where you are in. At least this is the perception that I do got. And I think one important uptake it is the lack of interest versus the capacity. So I don't know at this stage. Of course, in terms of the organization, we already have here different perspectives, and there is a lot of even for the clustering. I think at this stage, in terms of the barriers on the organization, I think we cannot do the cluster at this stage because they are really different. I think we can go to the barriers on the technical side. So Miguel, can you at least give us some insights on what is your views?
Can you listen to me now? Everything okay? Yeah, great. Okay, just to share my opinion on the technical side, I think the most important, the main barrier that we need to overcome is to provide citizens with the ability and the capacity to have to control their own data and to ensure that they can have portability of their own health data and they can like travel within the EU and they can have access to their own to their health data by their cell phones and yeah, that's the main technical barrier from my point of view. Sorry, Vanessa, you are moving. Yeah, the technical was done. Okay, moving to the financial. Okay, let's see what you guys have shared. Can be expensive to implement. Do not have we do not have a common European health insurance. Okay, so we need this relates more with governance, I guess. Reimbursement system, yeah, that's the main barrier. Like a model and a scheme for reimbursement and that can, yeah, that all countries can agree on. Sure, yes. Lack of earmark financing, lack of reliable evidence of the benefits in the financial. Okay, we do not. Okay, I think that's it.
I think, for example, on the side of the financial, there is one topic that I'm seeing in the chat by Vanessa Berry from Scotland. Is of course how can the citizen be in the process itself, and of course this very connects with the insufficient funding and investment in the modern equipment for hospitals do not to permit this bridge between the capacity and the need and the demand for the citizens and what are the need and demand for the healthcare professionals. So I think this is again a cultural change, and like Professor Krishna has said, how can we apply the digital transformations and to be in focus of telehealth services to apply changes on the society and on the way that we provide healthcare treatment. And of course, this funding mechanism and investment, it is a very important uptake.
Yes, and just to complement the financial barriers, one thing that I have read about, the national health system costs, telehealth related costs are not specified. So the costs that the national health system have are seen and analyzed as a whole, and it's a barrier to bring out the evidence that telehealth can be an added value for healthcare, and it's a barrier. So one enabler could, I don't know about the enabler or the solution, but we should take a closer look to telehealth cost effectiveness. It's very hard to, yeah.
So I don't know, any colleague in the room that would like, let's say, to comment. You don't need, let's say, to comment on the financial. Of course, your inputs in the all the section are very much needed. So I think we can just move to the next part, of course, in terms of the clinical and the cultural. I think, at least for me, in my perspective, one important clustering of information that we need, it is about, let's say, e-skills for professionals. So it is how can we foster the medical education with providing specific digital skills for our healthcare workforce, not only to physicians, but as well to nurses and other healthcare professionals that are going to be the end users, or let's say the providers, in this case for telehealth services. So I think in a way this would be at least one important uptake that I don't see in this part.
And moving to culture ones, which actually some of those in the clinical can also be seen as a culture one, because a lot of the time the fear, right, the unknown, the there's sometimes a resistance to changes in process, and it's not necessarily like something that will impact it because it's something new. They might have that resistance to accept, which comes a lot with acceptability of remote consultations. Some healthcare professionals, even patients, prefer personal contact, and while others see the benefit because telehealth is not supposed to substitute this, but to improve the systems that already exist. And looking about this, so I can cluster some of these ideas together.
For example, one important activity when we do see this interaction between, let's say, cross-border telehealth services, it is about, let's say, the language of the differences. Because, for example, when we saw the slide from Frederick about, let's say, how is the US, we know that, for example, in the US, let's say the main language of all the states are English. And for example, in the European Union, we have, let's say, different languages. And I think that it is a kind of a real difference on how can we come up with this mutual recognition on the language level, and of course to sharing best practices on the border regions, or of course in border countries. And another dimension is how can we have mutual trust and to bear in mind all the cultural differences that may arise from the different countries. So I think this is one level that is important to understand these cultural barriers. In terms of the one important topic in terms of this cultural, I think this is still in beneath, and it is a very important one on the right side of the screen. It is the lower of the level of the digital literacy. So it is very important that not only the patients, the citizens, the overall population, but as well the healthcare workforce have the right empowerment and understand the advantage and how to use digital tools. And I think this was a very important topic.
Another one that I find is very interesting is the big brother feeling. I think that's something that definitely makes citizens more reluctant to share their data and will definitely affect telehealth care. And I think this was a great contribution. And we have some comments in the chat.
The chat. I think both of the comments, let's say that by Francisco, by Donna, and by Stefan are very important in two different dimensions. The one about, let's say, that Donna, I think it is a very important one about, let's say, how can we build the citizen trust on how the data is processed and what it is the advantage from it to give them upon. And of course, the second aspect, it is a very important one that Stefan, that I know. By the way, hi Stefan. In terms of the digital foundation of to adding, let's say, digital health on the medical curriculum, I think this is really one of the uptakes, not only for the telehealth services, but as well for the digital health or the e-health dimension. Thank you so much for that. So I don't know, at this stage, I think we still have a little. Yes, Frederick.
Yeah, I just wanted to say something on the previous topic regarding sort of the cultural aspect. One of the things I think about the bad situation of the past year, one of the possibly good things is that at least telehealth and teleconsultation has now become more and better known to the general public, to patients, etc. Because for 20 years, I mean, within our group, we see a lot of people here today whom we've known for many years and who are telehealth experts and advocates, and but outside of this group, for the general public, 90 or 95% of the population, this has always still been very far from their daily practice, their daily knowledge. For them, they know about going to a doctor's office, going to a hospital, but doing a telehealth teleconsultation, or doing some form of remote monitoring, etc., is still, that was only for a few people who were involved in some pilots and etc., etc. So I would say from that perspective, at least the good thing is that more people now know about it, and there may be sort of a bit of a demand-driven action towards patients, citizens also asking for and wanting more convenience from being able to do a telehealth or teleconsultation and so on. So I think that's an important issue to note. But of course, in some cases, there will still be some resistance. There will be a bit of lack of trust, etc. And that for those things, there are other ways to try and well, not prevent it, but get around that, maybe through what I mentioned about accreditation and assuring the quality of such services, etc.
Thank you so much, Frederick. I think that was an excellent uptake in terms of that we consider telehealth services as an important tool to provide high quality of services to the citizens. And of course, the other enabler on what you have said, it is how can telehealth services be practiced without compromising the quality of care? I think this is really two important enablers that we do have in all the cross-sectorial domains that we are clustering here. So I don't know, anyone would like to say to intervene, because I think this intervention from Frederick, it was very good, and I'm really pleased that the people are interacting in the tool, are coming up by speaking. Of course, this is the first workshop, and we are going to have a second one. So of course, this is always a little bit difficult to break the ice in some of these sessions, but please take the floor and there is no bad comments. There is only, let's say, brainstorming exercise and input to the session. And by the way, thank you so much for all the comments that are still happening on the chat. So I think, Vanessa, do you like, let's say, to right now to pass for the last part of the slide, because I think at this stage we have a kind of a good overview between, let's say, the enablers and from the challenges. And I think the most idea it will be, let's say, what do you think that we can try to prioritize, or at least what do you think are the most important topics that we came here today, at least that we should focus on? So this is the kind of the core objective for the next 5 minutes as a closing part of the event.
Okay, great. So we'll go to the voting, and each person has 7 votes that you can, just a moment for it to change. Right. Okay, it's a little bit slow. Okay.
We need, let's say,
okay.
to give some coffee to the tool.
Okay, wait, it just moved to the end. So let me just pass. Okay, I'm having some technical difficulties. Just give me a second. Okay. So you should be able to vote. Yeah, so you can open the different question and just thumbs up the barriers or enablers that you like to, one, be addressed, others being reinforced, and we'll give about 5 minutes for this part and then see how it goes. So we have already someone that broke the ice. That's great.
So this is, I think this is one important exercise that we came up with. Is, let's say, we want, of course, it's going to be difficult to close the numbers of votes. You can still vote because this is more or less, let's say, an exercise that can be done in parallel when I'm doing these final remarks. So we got, let's say, from this 20 minutes or let's say 30 minutes brainstorming exercise, we came up with 109 ideas from this brainstorming session. So of course, this is an excellent contribution that we, 2 hours and a half ago, we had some difficulties to understand what is cross-border telehealth. And I think we have made a tremendous job in the short period of time to really come up with good ideas, good interaction for the people to understand what it is the global overview, what Portugal it is conducting at this stage, what Andalusia is doing at the regional level, now, moving towards Scotland to understand what it is this connection between Scotland and the Netherlands. And of course, in the other way around, we saw the tremendous effort that India it is doing to forecast telehealth from Himalayas to the rest of the country. And I think it was really astonishing to read the amount of data that they have, not only to provide telehealth services to the citizens, and of course to have, let's say, teleradiology or teleophthalmology to some these initiatives. Of course, this is still a first exercise. We want, let's say, for you to participate in a second workshop and, of course, in the summit. That telehealth will be for sure one important dimension and one important subject to be uptaken. And these barriers and some of these sessions that we do have here today on the citizen control of the data, on the liability, on the legal framework, and of course on the organization second, will be the core DNA of some of the sessions that are going to be handled in the summit itself. So, of course, for some of you, this will be a little bit still have some doubts about this initiative, because at this stage, there is a strong involvement from all the governments on the primary use of health data and the exchange of health data across borders, and of course, with the secondary use of data by the public health institutions or by the research, and how this cross-border telehealth will be. So we really see that at this stage, it is very important that we gain momentum on telehealth, because this will be an important feature for all the healthcare providers, all the healthcare actors that would give an additional contributions to increase the healthcare quality in terms of the national, regional, local, or cross-border initiatives. And I think this will be plugged to the primaries of health data, but as well will for sure gain trust, liability, and the empowerment of the citizen for the secondaries of health data. This is why that this specific initiative was a very important one for us as a presidency. So at this point in time, I think we are almost hitting, let's say, 50% of the votes forecasted. So let's try to see if we can hit the 60s for us to close the session. So at this point in time, just some closing remarks. Of course, I was delighted to have this session in face-to-face in Portugal. Of course, due to the COVID, it was not possible. Even this exercise, it is more difficult to be organized in these type of virtual settings, but in the other way around, it was really possible to come up with good contributions by your active participants to the workshop. So a round of applause to you that participate in the workshop, that came up with your time on a Friday afternoon to come up with good ideas. I think this was an excellent topic. So Vanessa, just because I'm curious and I know and I am always a curious guy, just to pop up some of the votes that we do have, at least from Custody, for closing the event.
Okay, so 52% of votes. So I'll move to the next one and the results. So barriers on legal, regulatory, and organizational and enablers as well. That's great. So barriers that won, let's say it's not one, but we'll definitely look around, and I'm going to open just to have a look at them. This is the barriers of the legal and regulatory level. So sharing of data, which is right now something that the European is actually moving forward with a lot of initiatives and regulatory framework. It's something that will definitely affect the telehealth service to be running at their full extent. And then we have, okay, in the financial transaction, having clear frameworks that will help to framework how this should be done, and will help then at the organization, of course, level to be able to do it. Different invitations, yes, that's a very important thing, because we are using different systems, different, even the operational level, it will be different. The GDPR, of course, portability of data is definitely something very important, especially to think about remote monitoring types of services. Less courage to challenge regulations, and I think we can move to the other ones, but definitely sharing data will be the top one in this sense. Then at the organization level, different healthcare systems okay, this is the same basically, but yes, common process or mutual recognition of different process will be very important to address. The hierarchy is the different levels of system, right? Because some have national strategies, other regional, other are federated, and some have a national health system, while others not necessarily. And this definitely will undermine this. And then we have the fraud control, of course. And moving to the technical ones, of course, interoperability. We needed to make cross-border telehealth service a reality. The basics infrastructure, right? We need to have a local system working to make actually this working between two countries. And yes, the already cross-border tech that already exists, although I see that as an enabler almost. Moving to the financial one, reimbursement, which I think is not a surprise. Do you like to comment, Diogo or Miguel?
Yeah, I think we just saw that as a very important uptake in terms of financial. So I think we can just split and go just for the first most voted. I think it is easier for us to, in terms of the main reasoning. So I think it is, in terms of the financial, it is not really a surprise, but the surprise will be how you will do it. At the national, at the regional, or at the local level, this reimbursement system or reimbursement framework. So I think we can go to the next topic. I think it is about, let's say, the barriers in terms of the clinical. So I think it is, of course, the semantic issues that they may exist, and of course there is a new European way to see clinical network and guidance. I think this is a very important uptake as well. I just will uptake now the cultural, and then let's say to move to Miguel to some of the enablers. So I think, like you have said, let's say the language barriers, but I think this is possible to use if we link it to the semantic asset. And of course, the topics like Donna and Nessa have talked in the chat about, let's say, the citizen have little, no faith or trust in the health services itself. So it is, let's say, this concept on how can we really move ahead with some of these dimensions. Miguel, just some wrap up or quick wrap up on the enablers.
I was speaking from Diogo's microphone, I guess. Sorry. Yes, EIDAS, trust and authenticacy. Yes, the main enabler. We have regulation coming out soon, so this we can leverage that. We can move forward, Vanessa, from the legal regulatory. Okay, the organization share good practice and experience. Sure. So this is like connecting all the relevant actors for higher exchange of experience, definitely, and national telehealth strategies. Yes, exactly. So we should have, in order to have higher exchange of best practices, we should have like national strategies or at least some similar bodies in each member state. So next one. For the technical, and that was for the technical technology aspect are easy to overcome. Yeah, interoperability. Okay, for me here the technical, it's the European Electronic Health Records Exchange format. We have the technology. We just need to deploy the things and to leverage the infrastructure. Okay. Financial cost-effective evaluation methods for public health service, dedicated budget, yes, to give a special emphasis to telehealth and to emphasize the added value of these tools, and health will be digital in nature in the future. So definitely telehealth needs to have a special place in the health sector. Okay, and the last one, I guess, is culture, right? Clinical, first clinical or support is like here. I think quality improvement approach. Okay. Yes, and evidence-based practice. Yeah, evidence. Everyone needs to perceive telehealth as a added value tool. And finally, the culture awareness raising here the role of breaking silos, engage the ecosystem, have yes, and have all the stakeholders talking to each other. I think it's the way forward with for the digital literacy, and have everyone engage and with everyone working towards the common goal. And yeah, I think that's it.
Okay, so I will close, let's say, in 1 minute with just, let's say, one important sentence. So for us, that we saw in this specific workshop that there is a dream, although we see that it is possible to have a reality. It is possible to really deploy these cross-border telehealth services if we join forces, if we share experiences. But but in the nutshell, it is very important that we have a common vision and a common strategy for how to use telehealth services for best healthcare delivery at the national, regional, and local authority. So for me, the main uptakes in terms of the challenges and enablers are 3 of them, that we should focus on the processes, on the people, and on the technology. And I think this is the 3 clustering of information that we are going, let's say, to provide in the next upcoming months. And of course, we will close with the eHealthSummit.pt. Everyone that attends on today's session is more than invited to be and participate in the second workshop on the 14th of May. And of course, in the eHealth Summit that will be on the 1st and 2nd of June, that will be free of charge. It will be open to everyone. The sessions will be on demand, and we will have this section that was pre-recorded to be available as a wrap-up session in the official website of the eHealth Summit. So thank you so much for your participation on today. Have a nice weekend, and thank you so much for your time. Thank you. Muito obrigado.
Thank you, everyone.
Obrigado.
Thank you very much.
Thank you guys.
Thank
for
you.
Thank you guys.
Thank you.
Well done.
Thank you.
Bye.
Thank you.
Thank you.
Have a nice weekend.
Yes, have a nice weekend, guys.
Well,
Thank you so much.
thank you, everyone. No.
Bye.
Força. Bye.